early morning. Okay, so what we've got is I want to tell you about pathological myopia, which is not a pandemic like COVID, but it's definitely an endemic in our country. And I'm getting to see more of pathological myopia now. Probably it's that we're doing a better quality imaging, or we were never looking at areas which were supposed to be looked at, or is it that increased screen time as well as the children being subjected to more of, as I said, screen time and more of indoor activities, unlike Singapore and all, where there's a law that you have to play out in the sun. And now numerous studies have come in that you have to use some drugs, diluted atropine, or make the children. So anyway, there's a lot of pathological myopia even in the younger age group, as well as in the middle age group. And you get amazing findings, various kinds of staphyloma. And just I want to share in this short time what kind of what mistakes we can make and how to rectify those mistakes. Because once you get a case of high myopia, you've got to look at not just the indirect periphery of the retina. So it's important that all these cases, its prevalence is 10%, I think even more. Every outpatient, you get to see many cases such like where they have diminution of vision or slight blurring of vision. So I'll try to highlight some of the things. If you high myopia, please check with the OCT. It could be a spectral domain or a swept source. It needn't be a swept source. It could be a spectral domain OCT. And you can see all these findings, which are very characteristic. This is a macular schisis, inner macular schisis, outer macular schisis. And this is like what we call it a compound macular schisis in a case of a pathological myop. When you have these kind of findings, the visual acuity is definitely disturbed and it requires a careful follow-up. Such cases can often be due to the anomalous posterior hyaloid, posterior vitreous, which adheres to the retina abnormally in the posterior pole. This is the abnormal attachment. That's why you get vitreous schisis. There is a layer of the vitreous which gets adhered to it, which starts pulling it upwards. The schisis increases and finally leads to a hole, and the hole leads to a retinal detachment. So you have these kind of findings when you get this hole formation. Just 3 days back, we had to operate a case. Vision dropped because she had schisis, but then on her last visit, she had a hole. Once there's a hole, it's a direct pointer that the retinal detachment can occur any moment. So these are the kind of patients we often see with bilateral pathological myopia with hardly any contrast. So the only way to pick them up is this imaging techniques which we are highlighting in this session. This is a OCT which shows the macular hole over here in the schisis. The macular hole is there, and this is not retina which is detached. These are actual schisis. So, and there's another retina, the left eye, which is having a detachment. The retina is lifted up, and it's also got a hole on one of its slopes. So you've got to manage it at the slope. So I'll just show you a little bit. So just a short video of the worst eye which we did. The axial length was 35 millimeters. Anything beyond 28, 29 millimeters, I realized that it's very tough to get the instruments to reach the posterior pole. And I tried with the long instruments, the myopic instruments, but they don't work very well because there's hardly any choice of array of instruments. So you usually have to manage with the existing instruments. You may take out the cannula, you may depress the sclera, or you may make the openings a little 4 millimeters. Definitely these eyes should be pseudophakic to get a better view. And even if it's a clear lens, I'd rather have them pseudophakic by an expert phacosurgeon. And what we do is we use the suction to remove this hyaloid. So this is actually the vitreous schisis. And the triamcinolone crystals have identified the vitreous schisis. The IOCT is of great help because it picks up the hole and tells you exactly where the hole is. So the IOCT in the non-contrast pathological myop patient for surgery, also a form of OCT, but you do it intraoperatively, really helps. You stain and then you put perfluorocarbon to stabilize the retina. And once you stabilize the retina, what you do is you take out this brilliant blue, the dye which stains the ILM. And then what you have to do is next is, I'll just show you, is we remove the dye. So then what we're doing is, we got a very thin macula over there, but thanks to the OCT, we have been able to pick up the hole. We know exactly where to peel the ILM flaps and bring them there. I'll go on forward. And so this was a pre-op picture which was seen in the slide before this, where we done the surgery, and now the patient's settled. So we are having results. Another thing which I've seen in the last year or two is that myopic detachment. Somebody's got an. You got to mute it. यहाँ से तो पानी चपक चपक घर में जाता होगा पैर से।
क्या बोल रहे हैं?
You got a pathological myopic RD, and these kind of RDs also we see a lot where the detachment is actually occurred. This is not a MTMI or a previous eyes which I showed you where you had schisis. These are RDs only, and they come straight to you as if you got to operate on them right away, because of course you have to before they develop PVR. So what they actually have is a hole in the center. Because these pathological myopic, you see the axial length again is very high. So when you have pathological myopes or high myopes of this kind of axial length, it's important that you check for macular holes. And once you got macular holes, then the surgery requires that not only do you treat the peripheral break, which is over here, you also take care of the macular hole. So what we've just done here is that you've drained some part of the retina, subretinal fluid through the hole, and helps to settle the retina. And this is kind of, and then put in triamcinolone to make sure that you got a PVD, and then put perfluorocarbon liquid. And this was the peripheral break, but the peripheral break itself would not be enough. So we put in some brittle BBG dye just under the ILM, under the perfluorocarbon liquid. And once under the perfluorocarbon liquid, you make sure that you do the OCT to see where exactly is the hole, and then you peel the ILM so that it covers the hole again. So once you've got the ILM to blue colored ILM to cover the hole, then you make sure that the center, the macula is also taken care of, as well as the periphery. I'll go on further. And so of course, myopic CNV is very common now. I think all of us see it a lot. And you have these myopic people who come to you young age who develop myopic CNVM. And what we do is we, of course, inject, and they do well. Thank you so much.